Welcome everyone to Friday Office Hours. My name is Anna Shavers, and I will be your host today for an exciting presentation from two of our SAS Demonstration Project researchers. I'm going to go over a little bit of housekeeping and announcements, and then we'll kind of jump into the presentations. So please hold your questions to the end of our presentations. We're going to host a question and answer session at the end. You can also feel free to drop those in the chat though, if you want to go ahead and you don't want to forget your question. And so let me get started with those announcements. So the program, the All of Us Research Program, is seeking input on data streams to link within the Researcher Workbench through the Center for Linkage and Acquisition of Data, or what we call CLAD. This is ending today, so if you have any kind of feedback or thoughts, definitely try to get this done by end of day. We're going to use this information to really evaluate additional data streams to potentially integrate into the second phase of data linkages for the Researcher Workbench. You can read more on this announcement at that link, or you can also scan this QR code. So I'll give it a second or two for you to put that there. And thank you, Sam, for adding the link in the chat as well for easy access. Okay. Next announcement is the All of Us Research Program has greatly expanded the structural variant data in the Workbench's controlled tier. So if you haven't heard, the structural variant data is now available for 98,000 participants, which amounts to more than 1.5 million structural variants total. This actually makes All of Us one of the largest and most widely available catalogs of structural variant data. We're really excited about this. To learn more about that, you can visit that link or scan this QR code to really learn more about using the structural variant data in the Researcher Workbench. Okay, I'll give it a second for you to scan that QR code. Okay. Also, in case you've missed it, we had office hours. The last office hours was for funding opportunities. We were joined by Stephen Mockren from the Division of Medical and Scientific Research and Margaret Farrell from the Division of Communications at the All of Us Research Program. During the presentation, they shared information about grant and funding opportunities from the National Institutes of Health for research utilizing the All of Us data set. You can scan this QR code here to access the recording. So I'll give you a second to do that. You can also visit our YouTube channel where that video is also listed, as well as other office hour presentations from past office hour sessions. Or you can also actually access them on the user support hub. So we have multiple spots that you can find those. Okay. And last but not least, this is actually a really exciting announcement we were able to just add and is relevant to the presentation today. The DRC just added a new notebook to the data wrangling in the All of Us Research Program featured workspace. So in that featured workspace, we have added a notebook about SAS data wrangling. So seeing how to wrangle data using the SAS Studio application in the Researcher Workbench. You can scan this QR code. Please note though that if you do, it will give you the link, but you won't be able to access it unless you're able to log into the Researcher Workbench with your Researcher Workbench account. So definitely go into the Workbench at some time. You can see that Sam has dropped that link in the chat as well, and check out that new notebook. So now it's my pleasure to introduce our first speaker. Dr. Abdelbary is a clinical associate professor in the University of Texas Rio Grande Valley Physician Assistant Department. Her research interests include maternal child health, infectious disease, cardiovascular disease, evidence-based medicine, physician-assistant education, health disparities, and preventative and community health. During her MPH and Ph.D. courses, she participated in many variable federally funded projects looking at cardiovascular risk in Mexican Americans, physical activity, and tuberculosis on the Texas-Mexico border. So I am going to hand over the mic and silence myself and let Dr. Abdelbary speak on her presentation.
Good afternoon. My name is Dr. Abdelbary, and I'm here at the South Texas-Mexico border. I was part of the SAS pilot project for the all of us. My team comprised of me and my student. She is practicing PA right now in California. After she graduated. Um, if we can move forward with the slides, I guess. Just a quick overview about diabetes prevalence and disparities. US about 10.5%, our area where we live in Hidalgo County, we have a higher than that national average diabetes prevalence. We have very vulnerable population in our area, and we have a lot with end-stage renal disease. So we were labeled actually the fattest city in America a couple of years back, and we have a lot of diabetes, obesity, and other complications in our county here at the border. So next slide, please. So we were actually interested on looking at the diabetic medication management for our patients. And this is kind of highlight historical markers for medications, how they came along. So we started with insulin a long time ago, and then classes kept added on until, in the recent, again, past 20 years, there was a lot of revamp in the medication management for diabetes. So we got some new classes added on, like the GLP-1s, the CGLT2s. These are the most recent ones. They have benefits like for cardiovascular risk. They have benefits for other decreasing other diabetic complications. So these new generation medications have a lot of impact on the diabetic outcome. But as clinicians, we see still disparities in the prescriptions because of insurances, because of access, because of prices, because most of these newer generation medications are more expensive. Some insurances have issues with covering them and so forth. And also there's some maybe clinician profiling on who to prescribe these new medications to. There's a lot of reasons for disparities on these medications used. So that's kind of the main interest in our project. Next slide, please. So again, this is an exploratory study to, again, check differences in prescriptions for those newer generation medications. Again, the GLP-1s, the SGLT2s, okay, and looking, specifically at do minority populations get prescribed these newer medications at the same rate? And again, the healthcare coverage impact on the prescription of these newer generation medications. So these are kind of two study questions there. So we initiated this study on the Workbench not a while back, but before the SAS implementation project. We were kind of stuck on with R on it, and we had some issues. We left it for a while, kind of gave up on it because not because of the study, but because of the R and the Python options, until there was an opportunity for the SAS implementation project, and we went ahead and enrolled in the pilot study for the SAS implementation for this particular projects. So next slide, please. I'm not going to hover much about the study itself, but again, hypothetically, we were aiming to see, or expecting to see, differences in the prescription patterns between racial groups, and again, that the health care coverage has an impact on it. But I'll focus more on this presentation on the SAS side, not on the study itself. So next slide, please. So again, a list of variables we use for this particular study. We used age, gender, race, ethnicity, insurance, income. If you're familiar with the Workbench, you know that some of these variables will come from different tables. So age, race, gender, ethnicity, these will come from the demographic table. And then insurance, income, these come from one of the surveys. So this is self-report type of thing, the surveys that the patient filled. I believe it was the basic survey. And then the conditions were extracted from the medical records of the patient, and that they had to have type 2 diabetes without complication. And one of our inclusion criteria was their A1C level had to be above 8. So we only built our cohort on the above 8 A1C level. So basically, they are kind of on the uncontrolled diabetic side. Okay, we pulled from the medical records as well, medication classes. So these are the medication classes that we pulled. We pulled when they were prescribed, the date, and again, to kind of look at chronological, which first class was described, when they moved to the second class, and so forth, based on the prescription date. Next slide, please. Okay, so again, this was part of the SAS project. We initially started this pilot project in a pre-prod environment, which was kind of similar to the workbench that we're working on right now, except that we had to do some extra steps to pull in the data, which was a learning process for me, a very great learning process. But again, we conducted this on the workbench for the testing. Lessons learned is, again, number one, which I'm going to hover a lot on. I don't know how many minutes left, but understanding data structure is a key. So one of the most complex things with all of us is the data structure. And if you don't really know your data structure, it's a problem. Cleaning was done in the SAS environment for the demographic, for the medication data. We use SAS for cleaning, for analysis, for everything. But kind of we had some challenges with the survey data, because pulling the survey data, the way the data is structured on the workbench, when you pull the survey data, each question comes as a row. So we had I believe, almost 500,000 participants in this SAS pilot project, but I had, I don't know, almost 2 million rows for the survey data. So this was a big challenge to pull and clean into SAS. For memory issues, for other stuff, kept crashing. This was my biggest challenge in this project, but I learned how to kind of pull the data in Python, make it more transpose it from long to wide, and then export it to SAS. This made a big difference because again, the big, I don't know, the size of the data was a challenge with SAS for the survey data, but we had to go around it using a Python as a link step. Afterwards, after cleaning was done, again, we had similar SAS experience like any other SAS that I had used on my desktop before. The cloud environment was not much difference from how I had used SAS previously on as far as a desktop app. Next slide, please. So again, this is just kind of some numbers on the breakdown by race on the data set that I had built for the cohort as far as racial demographics. You can see also in our demographic data structure, you have a race variable, you have a race concept ID variable, and these corresponds to each other. So I used the race concept ID variables in the cleaning process to kind of recode. So I recoded white 1, black 2, Asian 3, whatever, the usual recode, I guess this shows in the next slide. So I used the race concept ID, the ethnicity concept ID, these concept ID variables in the cleaning process. Next slide, please. So again, after cleaning, you can save your SAS data file, right? Like any other SAS. You can use libraries like you have used libraries before. This kind of, again, goes over the Python that was used in the survey data particularly, and then the survey data was used as a CSV, and the CSV was imported into SAS. This kind of kink in the process, but went out was smooth afterwards. You could move to the next slide, please. So again, this is shows my demo variables, my categories for demo variables, and again, each category had a subcategory code, and these I used those to kind of, again, in the recoding process using SAS. So the next slide will show you how I transformed these subcategory codes into the SAS 1, 2, 3 that we're used to. So next. So again, we kind of did frequency here for the gender particularly. Then I used the gender concept ID to recode. So next slide. So again, just a simple recode code that all of us have used in the past, the if else. But I was using again the gender concept ID to change gender 1 is female, gender 2 is male, gender 3 is again not man only, not women. So again, I used the concept ID variables in the recoding cleaning process. Next. There you show after the recoding is now, gender 1, 2, 3. That's how variable is ready typically for the analysis with SAS. Again, after cleaning process, everything looked similar as any previous SAS experience. If you have used SAS before, it's just the challenges comes at the initial stage where we have to import the data and again, understand our data structure pretty well, do the cleaning, and then there you go. We're ready for SAS like any other SAS experience. I don't know if I have more slides or I'm done. I think that's another example for the race, similar thing. I used the concept ID with those numbers to again change them or recode them with if else to 1, 2, 3, 4, whatever categories I used. I collapse categories as I based on the parameters I'm using. So there would be others unknown, skipped, all of these I put like the skipped and unknown I put to missing. So again, any other cleaning required, I always use the concept ID variables, and these were the easier variables to use in the cleaning process. Next slide. Again, this is just a code, regular code if you're familiar with SAS, recoding the race concept ID into, again, numbers that SAS can read. So 1, 2, 3, 4, 5. Again, I put skipped, prefer not to answer as a dot, which is a period, which is missing. Since these to recognize as a missing data. I'm sorry. Next slide, please. Okay, this is my new race variable with again 1, 2, 3, 4, 5 after the recoding and regrouping, ready for analysis. Next slide, please. Okay, age, date of birth is provided. So I chose to calculate the age from just using the year. So I had used only the year portion of the age, and I had used, this was in 2023, so I used 2023 minus the birth year to calculate the patient age. These on the left-hand side is kind of the summary of the age variable after it was done. So again, I had a mean age of 57, and it gives me again the other stats about the age. Next slide, please. Medication recoding was challenging, and this again, it's not because of the SAS, it's because of understanding your data. And part of the challenge with medical record data in general, not just all of us, if working with any medical record, is how things can get it's kind of free space entry, like freestyle entry, and how things can be the same. So if we look at this code, all of these medications were coded as 10 because all of them are the same. So 0.5 ml diglutide, okay, in a 3 milligram per millimeter, or 6 or 9. For me, in my study, I just needed the medication class or name, not the dosage. So for me, all of those are the same class or the same category. So I had to recode many of the medications on the list to regroup them into meds name, and then I regroup the meds into classes, and then I regroup the classes into new medications or new generation versus old generation. So I had to redo all these recoding regrouping. Also, because the data pulls from different medical records, like different types of medical records, like EMRs. Sometimes the medication is documented differently. For example, I can have, okay, 500 metformin orally or 500 metformin Ph.D. orally. I mean, for my study, they are the same thing. They are metformin. So I had to do a lot of regrouping into meds and then meds into classes and then classes finally classified into new generation, old generation meds for the sake of the study. So next slide, please. So again, I ended up with about 22 meds names groups, and then I regrouped those into 9 classes, and then the 9 classes were further subgrouped into, again, new generation, not new generation. So kind of to use these in the analysis. But again, this is all part of the cleaning of the meds. Once I came to my final new old generation category, like a binary variable, that's where what was needed for my study. But we had to go through all these steps of cleaning. Next. So again, I believe this is my final slide about the anticipated experience. So again, anything forward after that is, after the cleaning process, is the same as any SAS experience, frequencies, regression, everything else. Some people were kind of hesitant about, okay, the SAS VIA on the cloud, is it going to be the same? It's particularly exactly the same as the regular SAS. It just looks different. For me, it looks better, it looks nicer, but the same, usage. If you are familiar with SAS, there's no much of a difference. So next slide. This is a code for, again, the logistic regression we had to run. So again, this is using a forward selection method, which means, and re-entering one variable at a time and seeing the effect. Again, we're do the GLPST, which is the outcome, which is yes, no, which is again new generation, yes, no. So that's the variable representing the new generation, yes, no. So we're seeing, okay, is this okay? What's prediction by insurance, race, gender, and we're using the select forward method. Next slide, please. Again, output looks the same if you're familiar with SAS. No any differences. Again, I mean, I just put an extra bit of the output, not the whole output, but just to show people, like, it looks the same like any other SAS output. Again, it's running you the model information, the observation rad, again, how many were used, and again, some of, again, the criteria, the AIC, the model criteria, and then the p-values for the likelihood and the world. So again, like any other SAS output would look like. Next slide, please. Again, this is kind of some graph, again, by SAS, odds graph. Again, looking at the odds ratio with the world confidence interval for, again, in between groups, like, categories for the predictors in the model. And I believe this is my last slide, unless I'm mistaken. So these are my resources. And again, other than the cleaning process, understanding your data structure, like any data, you need to understand your data structure. The SAS experience for me was the same.
Perfect. Thank you so much for that great presentation. Next, I'm excited to announce our second speaker. So Dr. Goldmann is a clinical associate professor in the Department of Epidemiology at the School of Global Public Health at New York University. Her research focuses on the social determinants of common mental disorders, substance use, behavioral health surveillance, and physical mental health comorbidity. She is also interested in the development of I knew I was going to butcher this, I literally wrote down the presentation.
You're all good. I can hardly say it. Pedagogical.
Thank you. Pedagogical. Okay. Approaches for teaching epidemiology and public health to diverse audiences. Previous work has centered on the role of neighborhoods, socioeconomic status, and social support in post-traumatic stress disorder in urban areas, as well as the mental health consequences of disasters and other potentially traumatic events. And I will now hand it over to you.
Thank you. I hope everyone can hear me. thank you so much for giving me the opportunity to present today. It was also amazing to be part of this opportunity, to have the opportunity to be part of this pilot project as a SAS user, someone very new to the All of Us data. I worked with Dr. Stephanie Cook, who is an ambassador, I believe, for this project, and has worked extensively with All of Us data. She is a colleague of mine at NYU School of Global Public Health, an assistant professor of socio-behavioral sciences and biostatistics. So she was really familiar with the data, so that was really helpful for me. And I brought in the SAS expertise, and we put our heads together to come up with an idea. And it's something that I'd wanted to do for a while, but didn't have the right data to do it. And this was really just pretty serendipitous. So in our project, we took advantage of, similar to Dr. Abdelbary, and I'm going to say a lot of the same things, Dr. Abdelbary, as you did too. I had a very similar experience, but as you did, take advantage of the presence of both survey and EHR data, and really trying to use those both because that's one of the big strengths of these data. So what we did, we looked at concordance between self-reported and EHR documented lifetime depression diagnosis in the All of Us data set. And I'm going to give just a tiny bit of background and some sort of rationale for this project now. Next slide, please. So as all of you must know, people talk, mental health has become a very talked about subject for good reason. The burden of mental health conditions, particularly common mental disorders such as depression and anxiety, is extremely high, with about 1 in 5 US adults experiencing a mental illness in their lifetime, 1 in 20, or sometimes the estimate's more like 25% in the past year. And this has been particularly exacerbated by the COVID-19 pandemic. So there was gaining attention to mental health in this country and globally before the pandemic, but the pandemic, because of its large impact on mental health, particularly of younger adults and adolescents, has really put this at the forefront. So I highlighted depression. We focused on depression in this project, but ideally we will replicate what we've done here with other disorders. One of the great things about these data is that they don't just ask people in the survey about lifetime diagnosis of depression, which is what you generally see in population-based surveys, but lifetime diagnosis of anxiety disorders, ADHD, autism spectrum disorder, psychosis, just as eating disorders that we really never see on population-based surveys. There are, of course, limitations to self-reported diagnoses, but we just really don't see this kind of information. So we're really excited to do this and then also to replicate this for other disorders. Next slide, please. So what we were hoping to do was to look at the concordance between people self-reporting in the survey that they had a lifetime depression diagnosis, and among those with a diagnosis in their EHR. So just to step back, I'm sorry, for a second, in our population-based surveys and Haynes, BRFSS, the National Survey of Drug Use and Health, this is what we generally use for mental health surveillance or monitoring in our populations. Well, they're particularly limited because oftentimes they're really just asking, have you ever been diagnosed with this particular disorder? And it's unclear how accurate the answer to that is. There's a lot of stigma around mental illness. To what extent are people not reporting it for reasons of stigma or other reasons, or not even really recognizing that they've been given that diagnosis? So what we wanted to say is, okay, among US adults in this data set with a diagnosis of depressive disorder in their EHR, and this is about 30,000 individuals in the data set, what proportion of these individuals did not self-report a lifetime depression diagnosis? In a way, it's to sort of validate that self-reported data, right? So to what extent are people not reporting it or don't know? So in what way is it discordant? And then not only to estimate the proportion of not reporting a lifetime depression diagnosis, even though you have one in your record, but also to see if there are differences by sociodemographic characteristics in this proportion between self-reported and EHR documented lifetime depression diagnosis. So the whole idea is to sort of think more about the measures that we generally use in our surveys and to provide a little evidence to see how good that measure is. Next slide, please. All right, so as Dr. Abdelbary was speaking about, you have to know your data and how to put the data together. And this was the most challenging aspect to me as being new to all of us data. The cohort builder was a new thing for me. And then once you build the cohort and your data sets, then merging them together, deduplicating in that process was quite challenging. But then I'll echo her again and say, once that was all done, SAS is SAS. So it was very easy to use and very similar to what I always see when I use SAS. But just to give a sense, the two analysis cohorts that were then brought together, the first one had the EHR depression code, but did not self-report depression. They were all 18 years or older. They did not report lifetime depression diagnosis in the personal and family health history survey, which is where that information is in the All of Us data set. But they had at least one EHR diagnostic code for depressive disorder, and the SNOMED code is as follows. That's the code that we used, though we could do some sensitivity analysis with that. The second cohort also had the EHR depression code, and they also self-reported depression. So also 18 years or older, had at least one EHR diagnostic code with the SNOMED code for depressive disorder. But this time, these individuals did report lifetime depression diagnosis in the personal and family health history survey. And just to note, in that survey, people are asked about diagnosis, not just of themselves, but of family members as well. We're focusing, of course, on self-diagnosis. So the reason I highlighted that in red is just to show you the difference in the groups. And that's what we're comparing here. Next slide, please. Okay. So other study variables, very similar to the variables that Dr. Abdelbary used. We use date of birth to calculate age in years. I think I did use the whole age, the whole date, not just the year, but it should make very, very little difference. And then put people into categories based on their age as you can see here, 18 to 44, 45 to 64, and so on. Race and ethnicity we used and combined to generate a variable that combines both race and ethnicity. And you can see the categories here: non-Hispanic white, non-Hispanic black, Hispanic any race, and so on. One of the things that we really are super interested in this data set is to get a bit more detailed in terms of race and ethnicity, and sort of drill down a little more, because there's so much heterogeneity in the groups that you're seeing here. And that's something that we'd like to move forward with a careful eye on cell size to make sure we're not getting too small into identifiable range. Gender, male, female, and other. I think I coded it the same way, Dr. Abdelbary, as you did. Sexual orientation we looked at as well. Highest education level, and we used person ID, that variable, as the unique participant identifier. That's what was there, and that was used to merge our data sets once they were in SAS and for deduplication as well. Next slide, please. Okay, so our steps of our statistical analysis: create cohorts using the cohort builder, import data sets to SAS. I'm not going to show that because that's that was part of the demonstration project. It's very difficult to show exactly what you did there. What was challenging, agreed that this was the challenging part of it, to understand what the cohort builder is, to understand what the data sets look like, and then to bring them into SAS. At the time that we were in the pre-prod working in that space, there wasn't a button to just press to go to SAS to analyze your data. I was very kindly, thank goodness, given SQL code. Well, it was based off of, I think, the R and Python code that was used, and was it a macro? It was a macro that was used to bring it in. And thank goodness for the team that worked with me, Isabel, Moira, and Chris St. George, who helped me with SAS to help me debug. It was just an issue of one parenthesis, that's always the issue. It's this one small thing. But once I was able to do that, then I had the data sets in there, and I was able to clean them, merge them, recode everything that I needed to do in SAS, just as I usually do it. At this time, I believe the button is there, so we can skip that whole difficult step now and just literally have our data sets brought right into SAS. But for those of you who have used SAS or are SAS users regularly, even outside of all of us or looking at this space just using SAS, I tell my students when I teach SAS, bringing a data set in is the hardest thing to do in SAS. So it remained that way. But I think now that it's been further developed, it should be no problem at all. So we did some variable recoding, which I'll show you, frequencies and percentages to describe all of our variables, of course, some cross-tabulation and chi-square tests to examine differences in not self-reporting depression by demographic characteristics, and then binary logistic regression to further evaluate these variables. Next slide. And this is all going to be very familiar. Just as you said, Dr. Abdelbary, this is what you do in SAS. What I will say, and I think it looks prettier too, what it was very reminiscent for me of, and I haven't used this in quite some time, so the name has changed, but it used to be called SAS University Edition. Now I think it's called SAS for Academics or something, and it was a web-based SAS version. And I used it because I had a Mac, and there was no SAS for Macs. And so I started to use that. It was easier for my students to use it instead of using a virtual computer lab and so on, especially when a license is expensive. So that's what it really reminded me of, that web-based version. So it was very easy to navigate. I actually found it much easier to navigate than SAS University. So this is just an example of variable coding. Similarly, I used the gender concept ID, but I also used the variable and its character, it's the string variables as well. It just depended on, I don't know, my mood, but it all lined up. But I wanted to just show you two different variables that were created with doing it a slightly different way, but very similar to what you saw previously. Next slide, please. And then, of course, just running a regular frequency procedure is standard. I ran them all in one. I was particularly interested in the prevalence of not reporting the self-reporting lifetime depression diagnosis. Now, remember, this is among people who had the depression diagnosis in their record. And you can see the first bit, the self-report 0 is the outcome that we were looking at. And it was almost 31%. So almost a third of individuals who have an EHR record of a depressive disorder did not self-report a lifetime depression diagnosis. So this was a very interesting finding. We did not expect it to be so high. Then you can see frequencies for age category and gender as follows. Next slide, please. Then, of course, we're interested in seeing whether that prevalence or proportion who did not self-report the lifetime depression diagnosis, if that varied by other factors. This is an example of race ethnicity. You can see the code above. This is just a way to do crosstabs between multiple variables and one variable at the same time. Nothing new here. This is general SAS stuff. But just to highlight our findings here, I focused on the row percent because of the way I set it up, and it basically gives the prevalence of this outcome, not self-reporting lifetime depression diagnosis, by category of race ethnicity. And you can see that it varied significantly by race ethnicity. One was non-Hispanic white, and you can see that's about 29%. It was higher, 38%, 37% among non-Hispanic Black and Hispanic any race respondents. So you can see that there's some variation by race ethnicity. Next slide, please. And then we put the variables of interest into a regression to see if they remained independently associated with our outcome, which again is not reporting the lifetime depression diagnosis. And you can see these are our odds ratios, and there were differences by age, specifically that compared to younger individuals, older individuals were more likely to not report, to self-report, compared to, for instance, females. Males were more likely to not report, but individuals who reported their gender as other were less likely to not report. We have to decide how we're going to interpret this because it's a little bit difficult to say it. So we're going to have to come back to this. And so on. And you can see that there were differences in these groups. Next slide. So just to finish up, we in our discussion, not reporting a lifetime depression diagnosis despite having a documented diagnosis in EHR was common, particularly for older, male, non-white, heterosexual adults and those with lower education. Our next steps are to further explore this discordance, not just by one demographic, but by the intersection of various characteristics. So by gender and race, by sexual orientation and race, and so on. Again, with an eye on our cell size to make sure we're staying above 20, which shouldn't be a problem here. But then also to look at different diagnoses, so anxiety disorders and other mental health conditions, and really capitalize on the availability of that data that's really generally not available in population-based surveys. Thinking just ahead in terms of explaining our findings, it may be that we're seeing this discordance because of mental illness stigma, issues related to patient-physician communication. It's possible that I just did not take away from my visit that I had received a depression diagnosis, and just thinking about the way it's communicated to patients. And of course, limitations of EHR data may be that it was a miscode. So we might consider something like having more than one diagnosis in your EHR record. So we're going to play around with this a little bit. But the bottom line is that based on these findings, the burden of common mental health conditions based on self-reported data, diagnosis data may be underestimated because they may not be picking up diagnoses that people actually have. So we're going to look at the flip side as well, not having the diagnosis in your record and self-reporting, but we've got some work to do. But just a highlight of what we did. Thank you again for the opportunity, and thanks again so much to you all for being here today, and to the All of Us team that was so helpful as we worked on this. Thanks.